I'm Dr. Mike Milligan. We are here at the Cleveland Clinic with the American Academy for Oral Systemic Health, and I'm talking with one of the keynote speakers and person who was honored last night for his contributions, Dr. Tom Nabors of Oral DNA. Tom, thanks so much for being with us.
Thank you, Mike. I'm honored to be here.
Now, what we're talking about and the reason that we are co-branding with the Cleveland Clinic Wellness Clinic is because of the inflammation in periodontal disease is so significant in cardiovascular health.
Absolutely.
Heart attacks and strokes, the main killers. Tell us how oral DNA fits into this.
Sure. Well, I appreciate the question. If you recognize the whole center platform, it's wellness. In fact, medicine has to gravitate toward a prevention model in order to save itself and in order to save our country.
It's too expensive to treat, to go with the treatment
Absolutely.
model. We have to go with the prevention
Absolutely, it
model.
is.
Have to.
And so not only do we have to look at causation, but we also have to look at a risk model. And thus, as we look at cardiovascular disease of all of its type, arterial diseases that affect the heart, the brain, peripheral systems, and so forth, we have to realize that there are many sources that have either a direct cause or an indirect cause.
Right.
And what we do know is that periodontal disease has actually level A evidence that it is an independent risk factor for all types of vascular disease.
And level A is the best type of evidence.
It's best type of evidence. Many of the risk factors that are associated with cardiovascular disease actually have level B and level C evidence, but it's still recognized it's important enough to be used as a risk model. So to have level A evidence to confirm that periodontal disease is in fact an important aspect of systemic inflammation is a huge thing.
Right. So how does oral DNA help us? You're testing for the microbes that are actually causing our disease. So
Absolutely.
we're getting to the heart of it.
We really are. And what we've learned over the past 2.5 decades through our good friends that are in the oral microbiology world, and as technology has evolved, we now finally have recognized that there are real bad microorganisms that exist in the mouth called pathogens. Most of us have some very low levels of all of these types of microorganisms, but there is a new term that is occurring in our society today and in the science, and it's called dysbiosis. And dysbiosis is a shift of healthy flora to unhealthy flora.
Right.
And if we can observe that shift, then we can actually intercept disease prior to the end result of the disease.
Before it gets too late.
Before it gets too late. So periodontal disease, we've used clinical signs of disease as the determining factor, and in
Bleeding,
fact,
pocket depth.
that's the last stage of disease.
Right, that's the last stage. If we can get it before,
Absolutely right.
then we're on the preventive wellness model.
Absolutely.
There are 700 or 800 strains of bacteria,
Yes.
bugs in the mouth, of which there are only about 13 or 14 that are the bad bugs.
That's exactly right. When we look at the science, and if we look at the landmark studies that were published in approximately 2006 by Sokransky and Haffiji, they clearly show 30 to 40 microorganisms that can maybe fall in that category as being ones we should really look at. But having said that, of those, there's about 11 species that really have the current weight of evidence, meaning that they have the scientific data that states that they change the inflammatory process. These microorganisms actually create such a massive inflammatory response that they actually cause the tissue to move away. They break that attachment from the tooth. And so it's these microorganisms that are on our report that we have the best weight of evidence. It's not because we decided we only wanted 11, it's because that's where the science is today. If the science changes, we'll change our report.
Right, and then through that inflammation in the mouth, and not only the inflammation and those markers can transfer through the body, but the bacteria themselves have been shown to transfer through the body. So, oral DNA lets us identify what bacteria are in the mouth.
That's right.
We get it, we know which ones they are. The top 3 things that they should know.
Well, number one, they need to know that you can't measure health by looking at people.
Okay.
That the clinical laboratory model for physicians is to measure.
Right.
And you have to measure either blood, urine, or both, or other body fluids to determine if people are sick or if they are at risk for becoming sick.
Right.
In the oral medicine world, which you and I are a part of, we've always used clinical science because we didn't have any tests that could measure biological information.
Right.
So a patient needs to know they may be at risk even though they may look healthy. Or if they have early disease, they don't know how severe it is. So from a patient standpoint of view, they need to know that a test will validate whether they're sick or not.
Right, right. We were speaking with Dr. Hahn yesterday.
Yes.
There was a stillborn birth
Yes.
that the patient clinically had not much periodontal
Absolutely.
problem, but the bacteria moved from the mouth down and caused a stillborn birth.
Absolutely.
So it is significant.
Very significant.
So those are the things the patient needs to know. What does the dentist need to know?
The dentist needs to know that there's a way to measure that's far better than what we've been doing before.
Right.
We're not suggesting that clinical signs of disease should not be measured. In fact, we encourage every dentist, hygienist, periodontist, surgeon, and so forth to measure clinical signs.
Okay.
But that's just a record of past history.
Right.
And we clearly know from science that clinical signs of disease do not predict progression of disease.
Right.
And so the dentist, the hygienist needs to know that now we have a better way of defining the actual causation of disease. For the first time, we can actually determine which bacteria cause disease. And then we can determine also which bacteria present greater risk for bone loss.
Okay.
And so we can measure causation. We can also do a risk analysis based on these bacteria.
Okay, and we can do it specifically for the individual.
Absolutely.
Through your test. Okay, great. What exact people should be tested?
I would ask the court, risk for disease or you have disease. So my suggestion would be to every clinician, just like our physician friends would do, never do a clinical examination without a test.
Okay.
Because when we go in for our blood pressure and we go in for, and they listen to our chest, they always draw blood.
Right.
Why do they draw blood? Because 60 to 70% of all clinical decisions in medicine are made from diagnostic clinical test results.
Right.
And we in dentistry have relied on subjective factors for 100% of our decision making. Now, we have a very objective series of tests that provide extremely beneficial information to the clinician, to the patient, that drives appropriate therapy.
Fantastic. So I have patients who say, only take an x-ray if you see a problem. And I tell them, well, I take the x-ray to see the problem.
Yes.
If I wait to take the x-ray, the problem's too big.
Absolutely.
You're saying that the oral DNA tests for periodontal disease are exactly that way.
Exactly that way.
Don't wait till you see a clinical problem. Do the test to know beforehand so you can use the wellness model and prevention.
Well, when we look, and that's a great point, when we look at a risk analysis and we look at two particular microorganisms, P. gingivalis and Aggregatobacter actinomycin common as an example, it only takes there's a 2-month window that we have before we can lose 2 millimeters of bone based on concentration.
Okay.
And so we can actually determine at what rate they're going to lose bone with specific microorganisms that are in that patient's mouth.
Okay. How often should we do this test? You're saying...
It depends on the health of the patient. As an example, if we go in for our particular series of tests and we are healthy,
yes,
then the physician may say, well, you don't need to see me again for a year.
Okay.
Same thing is true for us. I think we have to personalize our diagnostics and our treatment based on the history of the patient, based on the disease that we find.
So a more disease-prone patient
Absolutely.
every 6 months?
Absolutely.
Or so,
yeah.
And a less disease-prone
maybe once a year.
Yeah,
Yeah, or maybe even 2 years if they're very healthy. I would also say, though, since we're all doing implants, I would encourage all of our dental colleagues to use both of these tests on every implant patient, the genetic test and the pathogen test. Why? Well, they've already had a problem.
Right.
Many of these patients are genotype positive for the IL-1 marker, which means they express inflammation much more aggressively. They tend to be at greater risk for tooth loss and also, interesting enough, a greater loss for implant loss as well. So to help protect our patients, let's give them appropriate information that they can make wise decisions on. And by the way, it'll also help protect us.
Okay. Tom, any last things to say before we close?
Well, the last thing I would say is thanks for the opportunity to talk about a passion of mine, and that is bringing the clinical laboratory model to oral medicine.
Tom, thanks so much
Thanks,
for being
Mike.
with us.
Yeah, I appreciate it.